Us move on to the next cranial nerve, that is the trochlear nerve. This is the nerve that does not have a nucleus, it has a nucleus. Sorry for that. So that is the nucleus. It has a trochlear nucleus. It is present in the midbrain. It is present just below the oculomotor nucleus, and it is present right here. You can see in front of the central aqueduct, cerebral aqueduct, in the periaqueductal gray area, and it has the same connections as we studied for the oculomotor nerve. It is getting fibers from the cerebral cortex. It is getting fibers from the cerebellum, oh sorry, not cerebellum, superior colliculus, tectobulbar fibers, and it is getting fibers from the medial longitudinal fasciculus. And all the three connections are for the same reason: for the voluntary movements and for the eye field corrections, for the tectobulbar reflexes, and for the medial longitudinal for the conjugate eye movements. Let us talk about its route. The nerve exiting from the nucleus is shown in the black here. This is nerve, it's unique in a few perspectives. It is unique in at least 2-3 ways. It is the only cranial nerve that is exiting from the back of the brainstem. It goes around and it exits from the back. As you can see, as it is exiting from the back, they are crossing one another and they're crossing the midline. So that is another unique feature. This is the only cranial nerve that crosses the midline after exiting from the nucleus. And it is the thinnest, most slender nerve. So it exits from the back, as you can see from this particular picture. It exits from the back. These are the superior colliculus, inferior colliculi. Below the inferior colliculi, it is exiting right here. You don't see the crossing grossly from the back because it has occurred inside in the superior medullary vellum. After the crossing, it moves laterally. It will hug the midbrain and it will move forward like this. It will go from the lateral aspect of the midbrain, and you will see it emerging from the lateral aspects of the crus cerebri. After coming here, it will move over the petrous bone, it will enter the middle cranial fossa, and it will move through the lateral wall of the cavernous sinus. You can see it going just below the oculomotor nerve here. So it will move through the lateral wall of the cavernous sinus. As it will move anteriorly through the cavernous sinus, it will enter the orbit through superior orbital fissure, the same situation, and it will supply only one muscle, that is superior oblique muscle. So it's the most slender nerve and it is only general somatic efferent fibers, and it is supplying the superior oblique muscle, and it is responsible for moving the eye laterally downwards, and it is responsible for intorsion, medial rotation of the eyeball. Intorsion means this arrow shows the 12 o'clock position goes to the inside towards the nose. So it is responsible for that. Let us ask the nice lady to help us with the functions and the pulses again. So this is the, let us talk about the superior oblique, and especially let's talk about its function of intorsion. So I have drawn these red lines. These are the reference lines that are showing the position of the eyeball. It's in the 12 o'clock position, normal position. The normal function of the superior oblique was supposed to be intorsion, rotating the eye like that. And as we discussed, even if the active intorsion is not taking place, the intorsion and extorsion are cancelling each other out, and the eye is being stabilized at 12 o'clock position in the normal position. Now what happens? This muscle was paralyzed due to the trochlear nerve palsy. And in the case of the palsy, the extorsion will dominate. The inferior oblique and inferior rectus, the muscles, they will dominate and they will move the eye outwards. And you can see this 12 o'clock position, it's not matching to that, and that's how the image of the one eye will rotate in as a comparison to the other eye, and you will be seeing two images at the same time. Diplopia. Now diplopia is very irritating. You cannot see clearly, you cannot move clearly. How do we compensate for that? Not we, any person with that. That person turns the head, that person tilts the head. You see, by tilting the head, you have forcefully moved this eye again in the vertical position. You have corrected the image for that eye, but at the same time, the other eye will be moved outside. But lucky for us, the other eye was normal. The other eye was having its superior oblique functioning. It will intort, it will rotate towards inside to match that eye. So now the image is established again. Diplopia has been removed. I am talking about this scenario because this is the point that is asked in your MCQs. You are asked the question that a person has come to you with a complaint of diplopia and he says that when I tilt my head towards the right side, my diplopia vanishes. So what is he doing? He is actually compensating for the superior oblique muscle palsy on the left side. So the person is tilting the head towards the healthy side. The person is tilting the head towards the healthy side. He is tilting the head away from the pathological lesion side. So that's the point you have to remember for MCQs. Let us talk about the other function, depression of the eye. It is one of the chief muscles that is for the depression of the eye. And if you remember the clinical testing of the oculomotor nerves, so for the extraocular muscles, this is the muscle that is responsible for movement of the eye downwards when you are looking medially. When you're looking medially, this is the muscle that is responsible for looking downwards. Again, I have discussed these mechanics in very great detail in my lectures for the orbit. You can see these lectures available freely in our YouTube channel. Go and explore that. I will add them to the description as well. So that is the, it is moving downwards, so that person cannot look downwards. And when you're moving down the stairs, when you're able looking down, that eye lags behind. So again, there is a diplopia. So you will be asked the MCQ that a person having diplopia when he's trying to move down the stairs. So that's the question that is usually asked. So that's the trochlear nerve palsy. I have skipped cranial nerve 5 to go jump to the cranial nerve number 6 because we will have a chance to discuss all the extraocular muscles at the same time. So we have now